Hi everyone. I wanted to talk to you a little bit about Module 6. I did not post anything yet, so I wanted to get this to y'all so y'all could look at it before Exam 3. Module 6 was very quick. It was only 1 week, and we had a test during that week, so that was kind of a blur. But we do need to look at that information in that module. We can't ignore it. I got several requests from students wanting to summarize or asked me about how to summarize chapter 4. So I went through it, and this is what I've kind of picked out that I think is important for you to know in practice as well as for the test. And as I said many times before, you will have this information in the future in future courses. So just kind of get the broad idea of what's going on here. And some of this you already know from practice already. If we look at things from a broad view, we have substance use disorder, substance intoxication, and substance withdrawal. Substance use is when the patient has been using a substance for a prolonged amount of time and abusing the substance. Intoxication, of course, is being under the influence of that substance. And withdrawal is a period of time after the substance is stopped and the patient is experiencing some type of symptoms. And this period will vary depending on several things, but usually a result of whatever they've been using. If the person has been using a substance for a prolonged period of time and the use is probably heavy, the person will most likely have some type of withdrawal symptoms. If they've been using for a couple of days, then they're not going to have these symptoms. You can obviously watch them if you have them in the patient, but it's probably not going to happen. Remember that patients sometimes fib to us about how much they've actually been using. If a person comes in for another reason, say they come in for chest pain and you're working them up for MI or hip fracture, whatever it may be, make sure you assess for any substance use because they could withdraw from alcohol, or they could already be taking a lot of opiates and you don't know about that, and you give them more and the respirations go down. So just keep that in the back of your mind in practice. There's lots of theories about what causes substance use disorders. There's a genetic factor. There's some discussion about neurochemical and receptor systems, and it is thought that the neurotransmitters most likely involved in substance use disorders are GABA, opioid, and dopamine. And you'll hear some information, or you'll see some information in the readings about the brain reward pathway, and that's what they're talking about with substance use. People have a positive response to substances, and they are rewarded for them, and they continue to use them on a regular basis. Sometimes people use for control of other symptoms of mental illness, like say that if they're real anxious, they may drink alcohol or abuse benzodiazepines. If they are having depression, they may use something to elevate their mood, or a stimulant of some sort. So we need to make sure that we're identifying any comorbid illnesses and treat those appropriately as well. In practice, you'll see a variety of substance use disorders. Make sure you pay attention to everybody. Just don't assume that if someone is 60 or 70 or 80 that they are not using substances, because I've had patients come in their 80s using alcohol, cocaine, opiates, abusing benzodiazepines, all kind of things. I've had homebound patients tell me the drug dealers will come to their house, usually at the first of the month when they get a check, and some of our older patients that get a monthly Social Security check. So don't ignore that. Make sure you pay attention to that as well. Alcohol use disorder is what you'll see. I can't say a lot, but we do see alcohol use disorder a lot. It's very common. And it can cause some significant medical problems. Of course, the damage it does to the liver, we know about that. If somebody's heavily drinking, it can cause cirrhosis of the liver. Thiamine deficiency is very common, and you'll see that patients sometimes can recover from that, sometimes they don't. So you need to be aware that if somebody comes in and they're detoxing from alcohol and they're a heavy drinker, it's important to put them on thiamine 100 milligrams Q day. And sometimes they'll do it IV on the medical floor, but on our unit we do it PO if they can take it, as long as they're not having a lot of vomiting. Alcohol can cause sleep disturbances, sexual dysfunction, anxiety. Take a look at the table on page 279. It's table 4-7, and it's got lots of issues that can be caused by alcohol use. Treatment, if someone is at risk for alcohol withdrawal, can be a medical emergency. You need to monitor them very closely. On page 276, there is a table 4-5 for symptoms to be aware of. Of course, we're going to check their vital signs at Q4 minimum, more often if needed, and we're going to treat appropriately. Sometimes you'll need to treat more aggressively than others. It just depends on what's going on with the patient. There's also a table on page 277. It's 4/6, and it's got symptoms of DTs. You want to prevent DTs, so you want to catch those symptoms in the very beginning and treat appropriately before they ever get to the DTs. We want to monitor and prevent any seizure activity, elevated heart rate, elevated blood pressure, elevated temp. There's example of treatment for alcohol withdrawal on page 281 in table 4/12. I think it is with Librium, if I'm not mistaken. And usually it's treated with some type of benzodiazepine. Lots of people on the medical floor use Librium. I've used Ativan a lot. I used to work with a doc that used Cirex all the time because it was not as harsh on the liver. I usually use Ativan because it's available to me. The dose depends on the symptoms. If I don't think somebody's gonna detox just because I've assessed what they're telling me, I'll start 0.5 Q4 PRN. If I think they're really going to detox, I'll do Ativan 2 milligrams Q4 scheduled. So that's kind of a pretty wide range there, just depending on what the patient's telling you. And of course, if the patient is telling you they're drinking more than they were and they want the Ativan, then you'll see the sedation and you'll back off of that real quick. And I didn't mean to gloss over alcohol use disorder. It's a very serious illness, and it can cause lots of medical problems. But like I said, we're going to delve into that in future courses as well. Cannabis use disorder, we're learning more and more every day about cannabis. I have seen people develop psychosis and anxiety as a result of cannabis use. Remember, this is not synthetic marijuana. This is what we're talking about here is true cannabis, not the synthetic stuff. I don't know what's in that stuff. They call it Mojo and all kind of other stuff, but it's the stuff they buy at the gas station and convenience stores and offline. But people do say that they have some withdrawal from cannabis. It's not really what people complain about a lot, but there is, and it's not life-threatening. And there is a list on page 289. It's in table 418. And so you can just look at that and kind of familiarize yourself with that. I do hear patients complain of not being able to sleep after they stop using cannabis. Opioid use disorder, we have heard lots and lots and lots about this over the years, mainly because people were abusing them and the respiration rates were going down and people just were dying left and right. Of course, we all know that. We worry about respiration rates and death. People can develop psychosis with high doses of opioids, mood disorders, sleep disturbances. Withdrawal symptoms are usually not life-threatening. People may think they are dying and they feel really bad, and I do feel for them. But vital signs are usually stable. And what we are seeing a rise in what they're calling fentanyl. I don't know if that's the same fentanyl we use in the medical world or what it is out there on the street, so I'm not sure what's going to happen when we see more and more of that. It's something synthetic, I'm assuming. I don't know what it's in it. But if somebody comes in and they've been using heroin for 2 years every day and they look like death warmed up, I feel for them, But I'm more worried about the person coming in that's been using alcohol or benzodiazepines for the last 2 years daily, because they are at risk for very serious medical problems due to withdrawal. And that's the next thing I'll talk to you about, benzodiazepine or hypnotic use disorders. This is mainly your benzodiazepines. We have to be very careful and decrease these very slowly for people, because they will have withdrawal symptoms, and also people tend to feel very anxious. And so you have to do a lot of education. There's a table on page 301, it's 427, and that gives you some directions on how to decrease those slowly. At one time, it was 1/4 milligram a week or something like that. I've done much quicker than that in an outpatient setting, but you do have to go very slowly on that. Stimulant use disorders, this is your cocaine, methamphetamine, synthetic products, abuse of prescription stimulants like Adderall, Vyvanse, things like that. There's a table on page 430, on page 304, and the table is 430, for signs and symptoms of stimulant intoxication. And we often see this in the hospital. They come into the ER and are hospitalized with acute psychosis, and usually about 5 days in, they are back to their baseline, which is good. Hallucinogenic use disorders, look at table 438. I didn't write the page down, I'm sorry. It has the effects of hallucinogenic substances. I think that this is going to be discussed more in the coming years with the use of microdosing medicine similar to this or in this family for depressive symptoms. So we'll see what happens with this this abuse. I hope it doesn't increase at all. I wanted to make sure that we don't see this a lot in the adult population, inhalant use disorder, but we do see it in adolescents. This can lead to delirium and even neurocognitive disorders, which are irreversible. And I've seen that over the years. And those are things people are huffing our aerosol cans and things that are in our home. So think about that with your middle school kids and adolescents. It's very serious. Years ago, I saw a young man that was on our adolescent unit, and I'm still seeing him, and now he's in his 40s, and he has had long-term effects of this abuse. It affects the decision making, poor judgment. I mean, they can't think clearly if they use enough of it, which is just horrible to see. I have down here tobacco use disorder. We know about nicotine. We don't really actively treat that in the hospital as an inpatient, but we always talk to our patients about smoking cessation all the time, and so we will continue to do that. There was a blurb about caffeine use disorder. Just remember that, and we know this, but too much caffeine for some people can cause significant anxiety and sleep disorders. I did want to mention steroid use disorder. Some patients can abuse these steroids, and they can produce a euphoric feeling, and then can produce symptoms that look like mania or hypomania. And some people have even become aggressive. These substances are addictive, and they need to be treated like an addictive disorder. So just pay attention to that if you have a patient out there that symptoms aren't matching up to what you think they need to be matching up, and they're using some type of steroids. And then gambling disorder, of course, that's not something they're ingesting in their body, but it can definitely cause lots of problems in their lives. And you'll see that comorbid, they will have substance use disorders, depression, and bipolar disorder. So the gambling disorder, I don't always ask about that with patients, but sometimes if somebody will come to me about, talk to me about major financial problems, and I'll start digging into, okay, why are you having, and if I know they're working and they're, should not be in the financial stress they're in, I'll start asking about, where's your money going? And so that sometimes brings up gambling disorders. I guess we need to assess that better than I do on a regular basis. as far as other treatment, once the patient's no longer intoxicated and not at risk for withdrawal from anything they've been using, they can be referred to psychotherapy and other outpatient therapies. I mean, psychotherapy is wonderful for these patients. AA has been around for a long time. It is not a professional run group, but it is very supportive. And then there's lots and lots of inpatient residential programs that provide therapy and IOP programs that provide therapy. And I did not get into all the medication assisted treatment in detail for the test, but there are lots of options out there for alcohol. There's a table 415, and again, I apologize, I did not write the page down. It gives you an overview of naltrexone, Camprone, Antabuse. I don't see Antabuse being used a lot anymore, but I did have a patient ask me for it a couple of weeks ago, and a couple of months ago, and I gave it to him. Naltrexone seems to be used the most, and it can be given PO or IM. And then for opiates, we have Suboxone and methadone. Methadone's been around for a long, long time. We do have a methadone clinic here in Baton Rouge that is very, very busy. If you go by there early in the morning, it's always very busy. But the patients have to go there to get the medication. And the other option is Suboxone, which they can take PO or you can eventually give it IM. So that's an option too. So if you're going to be practicing in a practice that's addiction based and you're seeing a lot of these patients, of course, you'll have to know this information much more than this quick overview that I just did. But I think this kind of summarizes the chapter pretty well and gives us an introduction to it. Of course, if y'all have any questions, please give me a call. Y'all have a good day.